Hello, everybody. Welcome to another AFR EMS case study. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And as always, joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
And today we're joined by Lieutenant Steven Siebert.
Hey, Chief.
LT, thank you for joining us. I appreciate it. So we're going to talk about a very pertinent case, and it's very prevalent in our department in terms of high-risk refusals. So this call was specific to Rescue 12. You all were dispatched to a 6 Delta for a female with trouble breathing. Pretty regular call that we go to. But tell us about what you saw when you got there, how the patient presented, and how the case kind of developed.
Sure. So this call was back in January. I think it came out around 5 a.m. in the morning. We were dispatched for 6 Delta, Rescue 12, Engine 12. On the way, kind of looked up in the notes on our MDT. There wasn't any previous EMS calls, but there were some previous calls for APD going out there for like either some domestic violence or disturbances and some drug-related calls for APD. So kind of have that in the back of my head, before we get to a scene. It's always just nice to kind of know about those things before. And we pulled up on scene. Rescue 12 was first on. I think the engine was coming from somewhere else in district. We walked in to this house. In the living room, there's just a single couch, and there was a guy there saying his girlfriend was having trouble breathing, that she just went to use the bathroom, and then she was coming back out. So maybe like a minute later, like she walked out to the couch and sat down. Looked like she was like talking, and like she was definitely breathing fast. But at this point, I went ahead and canceled the engine because it looked out of the gate like something that we could just handle with just the rescue. So I had canceled the engine, and then kind of talking between the boyfriend and the patient, trying to figure out what was going on. It sounded like she had been sick for maybe up to a week, that she's been having some trouble breathing. She talked to like a friend or family that said she was worried that she might have had pneumonia. So we start doing our assessment and looking at her, and she's working pretty hard to breathe, and she looks pale. So we start getting our vital signs. I think lung sounds were clear when we listened to them, so we felt good with that. She was pretty tacky. She's like in like 120s, 130s, I think, the whole time. Blood pressure 97 over 63, but she's like a 100-pound female, so it didn't seem super hypotensive to me. We had a hard time getting a sat on her. So we tried multiple fingers. I wasn't sure if there was like nail polish interfering or not. So like our room air sats were coming high 60s, 70s, but it was just kind of give a quick flash and then go away. So we couldn't get a very good pleth on her. And she was pretty tachypnic. She was breathing probably 30 plus times a minute. So we went ahead and put her on just a nasal cannula at 4 liters, see how she would respond. Didn't really seem to do much. So we went ahead and did a non-rebreather mask. She got kind of higher up into the mid 80s with the mask. Then tried to get into the story, really what was going on. Asked about if there had ever been any alcohol or drug use. It came out that she usually uses fentanyl about once a day. She last smoked last night. She's been sick like this for a week. Wasn't sure what was going on. Hadn't sought any care. And she was pretty worked up, and she was pretty anxious about the whole thing. She didn't really like us being there. And it was just her and a boyfriend in the house, it seemed like. So as we're going, like, she's not really progressing or responding to treatment as well as I would like. So I'm like, all right, like, let's get going to the hospital. Like, don't really know what's going on. But like, I know that you're sick. Like, it was definitely that sick versus not sick feeling. I'm like, you're sick. And so she's kind of uncooperative. She doesn't really want to go, but we were able to talk her kind of into getting going. I think Albuquerque ambulance was either level 0 or critical status. So we were going to initiate transport. We got her on the gurney. We got her in the back of our unit. We were able to start a line, keep the oxygen going. We were starting to do a EKG. We got the 4 on. We were starting to get the 12 when she really just adamantly did not want to go. She was pretty anxious. She started ripping out all the equipment there. And that's when I'm like, we need to have this like conversation here. And so like during that conversation, I feel like she was like able to calm down enough, like where we were really able to understand each other. And I just remember sitting there on the gurney, like talking to her. I'm like, look, I do not know what is going on, but I know something is wrong. Like your vital signs are not right. Like you're having a really hard time breathing. Like you seem pale, you seem anxious. Like there's something going on with your body that I can't give you an answer, and like you need to go to the hospital. And she was like, I'm like, I don't want to go. I don't want to go. Stay here. I'll go in later. Give me all these answers. So I'm like, so ask her A&O. She's with it enough where she seems like she's informed of her decision. And this is probably like one of like the most frank conversations I think I've ever had with the patient as far as like what the refusal means, right? And so I remember saying to her like, like I don't know what's going on. The risk of you not going to the hospital now, like, are up to and including death. And I don't know if that's going to be in the next 5 minutes, the next hour, the next week, but something is wrong and you need care. And she said, okay, like I understand that. I do not want to go. And so at that point it was like, okay, here's the refusal, read, sign, and we were able to assist her back into her house. And the boyfriend answered the door, like explained, she doesn't want to go. She walked in the house, went back to, assuming the back of the house, bedroom, I don't know. I remember looking at her boyfriend and being like, like something is wrong. Like we don't know, but she does not want to go. Like you need to do everything you can to get her to the emergency room. He said, okay, I will get her to go. Like we're going to go like right now. Like, okay. And so that was the end of that call.
I know the sats were kind of intermittent, and you started to get a good pleth. Kind of, she started to calm down. Did you have any other tools, like as far as end tidal, that you were looking at as well? Did she have good end tidal at the time?
It was fast. It was probably a little shallow on the waveform. Capno is low, but she's also breathing 40 times a minute, maybe at some point. So
we always say that we identify sick versus not sick. You identified pretty quickly that she was sick, but ultimately patients are allowed to make bad decisions in terms of their health care, and refusals being one of the highest risks, not only to us in terms of liability, but to the patient. I think you did a great job of kind of outlining what those risks were, making sure she understood what those risks were. She had a boyfriend who was willing to take her. So unfortunately, it's not what we want for them. And we typically try to guide them into what we think is best, but patients are going to have that autonomy and they're going to make bad decisions sometimes in terms of their health care. So it sounds like you did a great job. Criteria for refusal, Doc, we'll talk about that a little bit. I know it's always one of the sticking points for us. I know in our last refresher, Lieutenant Charles Bustos came and talked about a refusal that he took that he ended up having to testify on, and he had some great pearls for everybody as to how to document these cases. But tell us what you're looking for on the MSEP side in terms of when you're going to force somebody to go against their will.
Yeah, so the law is pretty clear for us. In my mind, I kind of like to simplify things down to two things that we have to have in order to force somebody against their will to go to the hospital. The first thing is a life threat, and that can be just a suspected life threat. That's a good faith judgment on the behalf of the provider. Any provider, it doesn't even necessarily need to be a physician. It can be the provider on scene has just as much authority under the law as a physician to make these discerning calls. And this patient clearly sounds like she could have had a life threat, right? She had very abnormal vital signs, clearly something wrong, which you identified. So she met that first criteria. But then the second thing that we need in order to force somebody against their will is the lack of decisional capacity. And that's where she was very clearly demonstrating to you that she understood the risks of the decision that she was making. And we respect that decision. I've had patients in the midst of a very clear STEMI, definitely a life threat. But if they're like, no, I'm never going to the hospital again, we just can't make them go. And that sounds like the situation you were in here.
Yeah.
It's one of those conversations, I think the question would be like, well, did you contact MSEP? But it doesn't really change anything. And I think you hit on that. Like, we have the ability to help guide that patient's decision making. If we were to paint that picture of what he just described to a physician, they're going to have the same answer as we are, that they don't have to go. So in those cases, it's not really a CYA. And I try to get folks away from that. Like, it's not protecting you or passing or shifting the responsibility to the physician. Like, ultimately that patient makes a decision. If they meet that criteria, they're good to do that.
I think the MSEP more is a phone a friend if it's a complicated situation to talk through, or you just need somebody to bounce stuff off of. MSEPs are there for that. The other thing is there is sometimes a generational gap out there. It doesn't sound applicable to this situation, but for whatever reason, sometimes you can say the same thing that I say, but if I have doctor behind my name, sometimes people will listen. And so there is an element of, I guess, authority. You can say, well, the doctor said you need to go. And sometimes that changes things. Not all the time, but I've seen that work before.
I think it really comes down to capacity. I think like we painted the picture of a patient who probably needed definitive care, but the capacity is what was key. Like we make a good faith judgment on their behalf. We tell them what we think, but if their capacities are to make that decision, then they don't lose that right, irrespective of what their vital signs are looking like. So,
Right.
And you took the extra step too of like coordinating a family plan. Okay, if we're not going to go, here's plan B.
Right.
And thinking that he was going to take her. So you made the extra effort.
did we respond back to this patient?
We did. So about 3.5, 4 hours later, sitting in day room, address pops up on the screen, 9 Echo, same address. And that was a sinking feeling for sure for me. I think I'd switched over to the engine for the day on engine 12. So we both responded. We got there and she was laying in the hallway. Her boyfriend was, trying to do CPR. So we got her out, started working the code, kind of asked the boyfriend, like, what happened? Like in the last, 3 hours since we were there. And he said that they had both went back to bed and that he woke up 5 minutes ago and she was unresponsive, pulseless. And at that point, more family started showing up. So I think the patient's mother and some other relatives were on scene too, and everyone was very frantic, understandably, but bordering on getting in the way of patient care, and it was kind of hectic. But we started the code. I think we got ROSC after 3 or 4 rounds. We got a ROSC back on her, so we ended up loading her with 5.5, started a pressor. We lost pulses again en route, and we went to Lovis downtown, turned over care to the team there. They got a ROSC again, and I think they ended up losing pulses again, and she ended up passing away. As far as the cardiac arrest went, it was very straightforward. We got a ROSC and things like that. I think for me, that was what was going on internally for me was hard. There's always immediately you're still running the scene and doing all these things I need to be doing, but in the back of my head, it's hard when you're you just saw this person a few hours ago and now they're in cardiac arrest, and you start second guessing things and should I have forced transport? What did we miss? Would it have changed anything? Dealing with family or the boyfriend, they're all pretty frantic, and having that in the back of your head, someone saying why didn't you take her? Why didn't you take her? So kind of having to work through all that on scene and just staying calm, being respectful, and getting the patient the care that she needed at that point. But at the end of the day, I kind of struggle through this a little bit, and going back, reading my first chart and things like that, and she was absolutely decisional, and something that I was told, I remember back to paramedic school, I don't know, it's always stuck with me, is that you can't always judge yourself on the outcome, but judge yourself on the process. And so being able to look at my process, what I did, those things were correct, and you can't always control someone's decisions.
Couldn't have said it any better myself. I think it's always difficult, and I think there's always that sense of what could I have done differently? If I would have done this, then this would have happened. But I think ultimately there was nothing that you could have done differently, nor the crew. Ultimately, that was the patient's decision. She met the criteria for refusal. I think you went above and beyond into the fact of hey, let's get in the back of the truck, let's talk about this. Even that was unsuccessful. And then following up with family or the boyfriend to say, hey, let's get her down there. They agreed. They didn't do that, obviously. I'm sure she was still hesitant to want to go. And obviously it was a poor outcome for her, but I don't think in any way it was a judgment on, the abilities and what you did the first time. I think the one key takeaway, and we learned that from Lieutenant Bustos too, was the importance of the documentation of these refusals. I think that's the biggest thing, is if you can stand by your documentation of exactly what happened on that call and why you allowed that refusal or allowed her to refuse, then as unfortunate as it is, anything that happens subsequent to that, that's what happened because the patient made that decision. So I truly appreciate you coming to talk about this and the fact that you took that time to work through it before you came here and talked. 'Cause I know it is difficult. I know as a young patient, 23-year-old, we never want to see that, but ultimately it sounds like you did the best that you possibly could for her. So it's a tough call. And I think what I would ask of you is, talking to the audience of new officers, seasoned officers who go through this, and you did it in such a professional and mature fashion, is what advice would you give them when you're taking these high-risk refusals?
Just go through the process. Like, don't, like, get your 2 sets of vital signs. Like, if you feel concerned about it, if there's any question on their decisional capacity, then, like, if you think that they can't make a decision, like an informed decision on their healthcare, then call a doc and force transport. In hindsight, like we were talking about the MSEP before, my what I understand for NSEP, if I'm calling an MSEP, I'm not asking necessarily their opinion. I'm going to call and be like, this is what we have. This is what I want to do. Like, is that okay? Kind of a thing. And with this patient in particular, like, she was decisional. Like, even if it was a bad decision, like, she had the right to make that decision. If I would have called, would it help me sleep better at night? Maybe, maybe not. But just, like, be sure that your process is good. Be sure that your documentation is solid. Go into detail. Have the patient read and sign the refusal. If you can get a family member to witness, I did not in this case, but I think that's a big takeaway. Listening to Lieutenant Bustos's refusal is, like, having someone outside of our agency be able to sign, I think is important too, if that's available.
And the liability piece, Doc, is always going to be there. I think you face that more than any of us as a physician. Like, the liability piece is always on the table, but that's not what guides our decision-making or our treatment. We're not thinking about, oh, what if this happens and I don't want to get sued, right? Mm-hmm. And I think we've tried to make it clear, like, in this culture of this department, is that if you're doing all those right things, you have a good process, you have solid documentation, and you are supporting your decisions, then this department, this division will always support you. And there's no liability and there's no feeling of guilt on your side. Like, you're doing what we asked you to do.
Yeah, you're acting in your best possible interest for the patient. You're having a very frank discussion with her, discussing what could happen, why you want her to go, and then making the extra effort to help troubleshoot how can we get you to go if you're not going to go by ambulance. And so I think we take a lot of refusals, but making sure that you're making that extra effort to cover your bases, not so much for a liability issue, but just to help the patient get the care that they need, and have that discussion with them, I think is really important. And you did a great job there.
Thanks.
Thank you. I appreciate you taking the time to come share. That's all we have for today. If anybody has any interesting cases they want to discuss, feel free to use our SharePoint tab, reach out to anybody in the division, and have you come down and come talk about these interesting cases. Until then, we'll see you next time. Thanks.